Hallo, goeie avond iedereen. Good evening. Welcome on our first webinar of 2021. Today we will talk about our digital dentures, FlitZ crafted by Carbon, and especially in combination with our Trios intraoral scanner. My name is Jean-François Bruxelles. I'm account manager at digital dentistry at Excent E-learning, and I'm your host today. If you have any questions, do not hesitate to put them in the chat. We have two guests. Our first guest is Dr. McMillan from the US. She is a prosthodontist, and she is working on digital dentures since 2015. And our other guest is Carlo Bacchus. He is our product manager at Excent E-learning, and he is actually leading our digital denture project in our group. So Valerie, Carlo, the digital stage is yours.
So thank you for having me. I wanted to just give a little overview of my presentation today. It's really intended not to cover everything about digital dentures, but mainly just how to make your records and how to get good information to your laboratory. But before I start, I just wanted to briefly go over who I am and what I've done in the realm of digital dentures. Some people call me denture queen, and it's not that I'm really great at making dentures, not at all. It's that I am really passionate about dentures, especially digital dentures. I've been making dentures using digital techniques since 2015, and pretty much all of the dentures that I make since then have been made digitally. I started out by having all of the dentures made by milling, and then about a year ago, I switched to 3D printing using Lucitone bases and Dentsply and some other options for teeth. I really love to study all different types of techniques with dentures. I like to get really high end with the technology that I use, but I also, here's an example of me wearing a costume that is made out of a Trios. If you can see, my lightsaber has a Trios tip here. But not only do I like to play with technology, I also like to study and make dentures using classic techniques. And so I don't want anyone to get the idea that what I'm talking about is making dentures in a new way that's different. We're still making dentures with the same techniques and making impressions that you have to have an understanding and a background in the classics. So as I was saying, the course is not really about how to make dentures or how to make an impression. This is really just a short overview of how to adapt protocols that you already know to the digital process. And not only can you take the protocols that you already know for making impressions, making, all kinds of records, you can turn these into digital denture protocols. All of the things I'm speaking about can be accomplished also with a laboratory scanner. So if you don't have an intraoral scanner, that doesn't mean this doesn't apply. All of the techniques that I'm sharing with you could also be done with that. However, there are some reasons to consider doing an intraoral scanner rather than a laboratory scanner, and I'm just going to talk about three big ones. The first reason to consider it is actually relevant today more than ever. Many of my patients have been concerned about the number of visits that they may have to come to the dentist to get a new set of dentures because of COVID. They are elderly, they don't want to leave their home, and if you can offer them a quicker 1 to 2 minute or 2 visits to get to a final set of dentures, you're able to offer someone maybe a process that they wouldn't consider before. If dentures take 5 or 6 visits out of the home into an office with lots of people, they may not want to do it. But if you can take their existing dentures shown here on the left, put an impression in them, scan them in your practice with an intraoral scanner, then you have a very good chance of being able to deliver them a new set of dentures at their next visit. So that's the top reason to consider doing it now. The next reason is that very many people actually don't like impressions. They are afraid, they have anxiety about getting dentures made. So it is possible, although not my normal technique, it's possible to offer a digital impression. And even though I may start with actually scanning the mouth, I'm probably going to add an impression at some point. But if you can offer the patient a digital impression, they are more excited about that. And then the last application is it's possible with the right type of records to take a patient who's having a very bad Thursday, and by doing the right types of scans, in my office, I was able to make this patient a temporary denture ready on Monday. That's possible with conventional techniques, but it's so much easier when you have digital techniques. So those are my kind of 3 reasons of why you would want to consider using the intraoral scanner. It's still the gold standard to use a lab scanner. It makes great dentures, but I think that if you've got a reason to incorporate the intraoral scanner, there's a way to do it. So kind of skip that one, but there's 3 basic things we have to get. One is you need to have good clinical skills to be able to make an impression, to know what the vertical dimension should be, to understand whether the teeth need to be moved facially, lingually, etc. Second important aspect is you need to be able to make good records and scan them so that they are usable by the laboratory. And then the third is to be able to share the information and to correctly transmit the information to the laboratory. So I always use a checklist, and I've given these checklists to Carlo here so that he can get those to any participants from today. The reason I use a checklist is that humans tend to forget to check everything. And when you're doing a digital technique, you can often skip try-ins or skip the final try-in if you're accurate and comprehensive at getting the right information from the beginning. Second, the checklist goes over step by step when to make impressions and when to take photographs, when to indicate what changes you need. So really, when you have a reference or a patient who has dentures, they like the dentures, they like the teeth, they have lost some fit over the years, they've lost vertical dimension, and they've lost the big smile, the tooth display. That is a perfect case for you to take their existing dentures, place a wash or whatever sort of impression you think is appropriate in their existing dentures, and then put them in the mouth, take a look. Does the midline need to be moved? Does the lip support need to be increased or decreased? Does the vertical dimension need to be changed? And if you're able to go through this list and evaluate these dentures after the impressions and convey the proper information to your lab, then you can have a great set of try-ins or possibly even the final dentures at your next visit. So I wanted to first just go over what do these items mean. If you ask for a change to the lip support or the incisal edge, what is the laboratory doing? So here, what we have is if you were to put no change at all, no change to anything, the laboratory is going to set new teeth in the exact same position that your record has their teeth at. So first, I'm showing moving the teeth superior and inferior. That means the incisal edge position. If you want it to be superior by 2 millimeters, you put that. The next category here is the lip support. If you would like the lip support increased by 1.5 or decreased by 2, you would write that. And so this is how the laboratory would change that aspect. The next one is, some people call it a cant or the occlusal plane. Here it's written as mediolateral aesthetic angle. If the teeth need to be shifted up or down, I would write down, move the right side up 2 degrees, meaning we would take the right side and tip it this way. And then the last factor here is the midline. Now you can request for the midline to be completely shifted, all of the teeth moved left, all of the teeth moved right by however many millimeters. But what I often do is just rotate the midline so that we can keep the arch form in the same position that it is in the posterior, but yet shifting the midline by a certain amount, just right at the midline. So really there are 2 different ways to change the midline, and it may, it does kind of depend on how the laboratory does it and how you want it done. But this is just showing me checking how much did I actually change this midline, and I moved it about 1.2 or 1 millimeter to the left side. One very common issue that I've heard from multiple laboratories, when they receive records like this, where we have a set of a patient's dentures relined with a bite. If you notice, the bite material contacts, but the anterior teeth here do not touch. So when the technician opens this case in the denture software, they see an open bite. The front teeth are not hitting because of the material and the bite record that was placed during the scan. So the technician is going to put the teeth exactly copying the upper, but where are they going to put the lower teeth? You probably don't want them to put the teeth exactly where these are because they're not going to touch. So the technician is going to put them into correct position with the upper arch. That means you have actually opened the vertical by quite a bit. And if you look at the overlay where the lower teeth are up much higher than they were in the patient's original dentures. Now, if you needed to open the vertical by that much, that's great. But very often when you have already added impression material, that would be too much. So the dentist, if they make a bite record that has an open bite, they need to then specify to decrease the vertical if they did not want that. Or if they did want it, they need to really clarify that. So this is where I have decreased the vertical. And now you can tell these teeth are more in line with how the patient's dentures were, rather than that opening with the change to the lower teeth. So if my intention was to copy those patient's dentures, this is how my checklist would look like. There would be no change to anything except I would request the vertical dimension reduced by about 3. So next, I'm going to go through 6 different scanning protocols for 6 different situations. The first one is for immediate dentures. My preference when you're making immediate dentures, or when I make them, is to obtain good intraoral scans for both arches. Many times that's possible. But what you're seeing on the screen here is what happens very often when I'm trying to do this. I get a good or a good enough scan for the upper arch, and the lower arch, we cannot get it. We tried, we can get the bite, but we can't get a great scan on the lower. And rather than giving up, making impressions, trying to going to get a wax rim made, this is actually really good to get these records because you've captured the upper, you've captured the bite, which wouldn't be easy to capture with stone models. And what I do is I pair this scan with another scan of an alginate impression of this patient's lower arch. Now, everyone used to say, well, you can't scan an alginate because look at those holes in the teeth. You can't, you're going to have holes. Well, that doesn't matter at all because we overlay this scan with the intraoral scans, and we don't need the teeth because we're going to be removing them and extracting them and making the denture. So this, with the intraoral scans, is all I need to make a great set of immediate dentures. And it doesn't always happen, but when it happens, you just make an alginate and scan your alginate in a separate session. Next, really, really great protocol is when you would like to duplicate the patient's existing dentures. So your goal is to have your laboratory make a set of printed dentures that are exactly like the patient's dentures. You would do this if you want to make a lot of adjustments, reduce the board, make some changes, cut down the teeth, because duplicated dentures make really great record devices. Then you can take those duplicated dentures and send them and have them laboratory scanned, whatever you want to do. So that's a great protocol to be able to duplicate the existing dentures. My recommendation, if you're going to duplicate dentures, is that you scan the entire denture, doing it the way that I normally do, where we start on the tissue side first. And then you're going to wrap your scan all the way around to the teeth and actually close the scan. So you're going to end up with a scan that looks exactly like the denture. The reason is that your laboratory doesn't have to do anything other than close the holes and print this object. They don't need to design a denture. They don't need to do anything else. So here we have the lower. Next, we do the upper. Now, a lot of people ask me at this point, I see that you're scanning the denture or spraying the denture with some spray. You really do that? Yes, I do. And the reason is that I find that the Trios is capable of scanning without the scan spray, but it does a better job and it gives me fewer errors when I am using the scan spray. So until the manufacturer tells me to stop, that it doesn't change it, it doesn't make any difference, I am going to continue to use a scan spray. So here I'm just scanning the upper and going through the tissue side first, then wrapping around to the teeth, and then closing it and completing it on the palate. The most important fact here, and I'm going to go over more about my scan path, is that you must overlap previously scanned areas with new scanned areas. If you try to just scan in any direction you want, it's not going to work. So that's closing the scan. The next technique is where we are going to use the patient's existing dentures, just like I showed earlier, make some wash impressions, make a bite, and then scan those. But our intention is not to just copy them and print them as an object. Our intention is then to take those into the denture module and make a design for a new denture or a trine. So I need to go back and just share my original classic video for how I scan dentures. I first presented this, I think, in 2017. When I'm using the intraoral scanner, I hold it sort of like a knife, and I hold the denture in my other hand like a cupcake. And I'm going around on top of the denture just like I'm frosting a cupcake. So I use this analogy to teach my staff what it's like, how they hold the scanner, how they hold the denture. And then my analogy goes even further, that once you've scanned or frosted the top, you then peel the paper off of the sides. And that's what I'm doing here by coming up to the border, going down to the teeth, coming up to the border, going down to the teeth. Now, there are other ways to scan a denture. Starting with the teeth first, I think, is possibly a good way as well. We may also, as research comes out, find even better ways, more accurate ways to scan the denture that I don't yet know about. But until they do, this has been the way that I've done it, and it has worked for me. So that's kind of how I'm teaching it still. So to just give you a graphic illustration, with the upper, I like to scan the borders first, because it has a lot of detail for the scanner to latch onto. If you start scanning in the middle of the palette, that's a smooth, flat, shiny, no detail surface. So that's why I've chosen the borders first. Then I fill in the top. I check for any sort of stitching errors, and then I go on to capturing the teeth. So on the lower, it's a little easier because you can usually scan the whole intaglio surface in one pass. And you want to, if your scanner is having trouble, typically returning to the palatal rugae area or to the midline helps it. The next movement is to return to your borders, and just like peeling the peel off of a cupcake, you roll down to capture all the way to the incisal edge and back. Importantly, you should not leave your bite registration on the upper arch. It is acceptable, and sometimes people prefer to leave the bite on the lower, but you cannot leave it on the upper, because your upper is the reference for your laboratory to be able to measure the incisal edge. And if you have the teeth covered with a bite registration, they can't see where that incisal edge and where the teeth are. So here's a video of me scanning a set of reference dentures, starting with the lower. I often take off the bite records and don't scan anything with the bite records on. So you're going to see that same path where I'm going to scan from one side to the other, filling in as if I'm frosting that cupcake. You want to get on a big glop first, smooth it out, and then spend your time kind of fine-tuning it. Once you've got that, you go from the border to the teeth and all the way around. I don't find it necessary to capture all the way up to the occlusal surfaces. As long as you have the facials of the teeth, you're good. Now here, if you notice, I didn't quite get enough on the lingual of that one corner on the right side. Next, I see I've got a couple areas I didn't quite get all of the detail there. So I'm just filling those in. It is really not totally necessary to get all of those little areas in every case, but you can work on it. What happens if the ridge is very deep and you can't get an undercut? You can't even reach the deepest point of that ridge to scan it. My suggestion is to go ahead, and if you feel comfortable with it, pour a model in the denture. As long as you've got enough impression material, you can safely do that, because at least you have captured the bite, you've captured the other arch with your scan. But if you're having a little difficulty getting into a deep portion, you now have a model, and you can scan the model in a separate session, and that model can be used as the tissue surface. I would say that over doing this in hundreds and hundreds of cases, that has happened to me maybe 3 times in the past five years or so. So it's rare, but it can happen. When I scan the bite, I don't scan the bite in the patient's mouth unless they have an opposing natural dentition. Now, I actually have to stop this really quick before, because there was a very important part that I needed to pause at. So after we have captured the bite, the trios is trying to be helpful, and it is trying to align the arches, making contact, thinking that this patient who's biting down needs to be able to bite on all of the teeth. They should touch. But that's not the case here. Nothing should touch. So the way that the trios automatically align this is not correct. And if you notice up here, it says adjust for contacts and the box is checked. When you're scanning this, you need to uncheck that box because the first alignment wasn't very good. So I unchecked the box and you'll see it improve. Watch here. Now it aligned it correctly because the trios was thinking it was going to help you out and it was not. So that is an important box to check if it's doing that correctly or not. So that's what we've got for that one. Next, let's say you have had a try-in and the try-in fits poorly. My first recommendation is that you go ahead and make some wash impressions, improve the fit, do whatever you need to do to improve the fit, and then cut off the cusp tips on one arch so that you'll have no interference when the patient bites together, and make a new bite record. Now, one suggestion is to just go ahead and ship these to your laboratory because now you don't have to worry about, did I not scan it right? What's going on? That would be a good idea. Second, though, is if you did want to scan these yourself, you would do it just like I showed with the previous video. But the one exception is that if you watch what I'm doing, I'm pointing out how I have left the upper arch intact, but have cut off the posterior cusp tips so that when I make my bite record, the vertical dimension is improved and we have no interferences in the posterior. Now you can do that with a try-in. You obviously can't do that with a patient's existing dentures. But if you see when I'm going through, I'm doing the exact same type of movement where I'm doing the tissue side first, then the teeth, all the way to the cusp tips, and so on. So really, I'm going to skip the rest of this video because it's about the same. Again, you do not need to scan the entire lingual. You do not need to scan the entire palate. If you do, it's okay. And your laboratory can still use the denture scans to make a denture. The downside is that they probably won't be able to get the color information from the file. The color is important if you've made any marks for the midline or anything else. But the reason I like to see the color is because if I have some tray pressure or an area where my impression, showed through, I can then in the software relieve that area. So that's why I like to get the color. And so not closing the scan means that your laboratory is better able to use the file. Although if you close it, it still works. Next is if you have had a try-in and the bite is incorrect. One option is to make a bite, send it to your laboratory. What I do is I do not just scan the bite on these records, but I actually do my exact same process all over again. I scan both of the try-ins as if they are going to be my final records. And in this case, I'm showing you the option of leaving the record attached to the lower in case that's what you wanted to do. The reason why I'm scanning the whole denture here is because I am using intraorally scanned records rather than lab records. And so it makes it easier for me to use these records to reset my bite in the software. Now, you probably don't need to do scanning the entire thing, but you can. Now, is your laboratory going to use the tissue surface here to make the next denture? No, and that would be probably a terrible idea because now you have a scan of a print making a denture. No, instead, they are able to use these simply to realign the bite and use your previous impressions as the tissue surfaces. So in this case, you could have adjust for contacts on. Why? Because the Trios is going to help you to sit these two dentures together, because the top should touch the bottom. So having the adjust for contacts feature on is good if the two scans are actually touching. Last, this is a little bit more of a complicated section. These are some options that you have for a patient who doesn't have any existing dentures. No reference, nothing. So where would you start? First of all, you can use digital smile design. This is my youngest baby here. One of the issues with doing a digital smile design on an edentulous patient is that they don't have lip support. So their upper lip curls back and it isn't quite natural. So to help with that, I place a papillometer under the lip to give it some support. And then the patient and you can look at, do you like the size and shape of these teeth? You know, what kind of, basically you get the size of the teeth. I have glued a ruler horizontally on the papillometer so that you can pick out what looks good on the patient's face and then translate that to, this is an 8.9 millimeter tooth. The next tool and device that I like to use for someone without dentures is the Ivoclar UTS CAD. So it's a really fancy mush bite is what we called it. It's a little device that the patient bites on with putty, and then you can attach an aesthetic plane measuring device called the UTS CAD. So what this does is it allows you to translate the intraoral models that you can generate to the aesthetic plane, the interpupillary line, as well as Camper's plane. In order to do that, you will have to scan the Ivoclar centric tray device, upper and lower, and bite. And then what your laboratory does is they use the scan of the centric tray in order to align it with whatever record you have given them of the patient. It could be, as you're seeing here, an intraoral scan of the maxilla and the mandible, which is going to be aligned to the centric tray. Another option is you could make alginate impressions and scan the alginate impressions with your scanner, and that file could be aligned in this same way. But once you have a scan of the centric tray and you have a scan of the patient, you can align the patient scan with the centric tray. And this gives you a preliminary bite registration. So I'll let that finish up here. Let's go ahead and there we go. So that's aligned. We'll do the same thing on the lower. Now, what would you make from this? You could have a set of custom trays made. Probably easier to just make alginates and send those. You could have 3D bite plates made from those, which is my favorite thing to do lately, which is a specific Ivoclar device that fits with a nathometer. Another option is your laboratory could design a set of tri-end dentures, and you could use those to make final impressions or reline them with a functional impression material and then have the patient wear those. So you do have a lot of different digital options, even if you've started with something like that. So here's my video on how you would scan a centric tray. First and most important, what I was showing you in that picture is that I have what I call graffiti on the centric tray. The centric tray itself is smooth, and an intraoral scanner doesn't typically do terribly well with smooth, large, flat surfaces. So by carving some little smiley faces and hearts into the tray, I am able to align the upper and the lower portion of this tray a lot easier than without them. One tip for this scanning this device is that the putty that is intended to be used with the centric tray here is extremely hard to scan without scan spray. So other products you can get away with it, but this one you have to have the scan spray. So now here I'm going to scan the bite, and then I'll use the graffiti to align the two portions of it. Now, in between my graffiti, I hope you can see that there's a faint horizontal line. That is the horizontal line that corresponds to the UTS CAD, or that device that was on the patient. So I will use that line, that seam, the horizontal seam line on this device in order to set my occlusal plane and make any adjustments that I need when I'm making the 3D bite plates or the tray indentures that I'm making after this. So I'm gonna skip to the next one. But before I do, it is extremely important to not have that adjust for contacts on, because here it's on and that bite is not correct. You have to unclick that box so that the Trios doesn't try to put these two scans together thinking that they shouldn't penetrate. They should penetrate. Last video here is how to scan an edentulous patient. I will be the first to admit that I do not very often scan edentulous patients unless they have teeth and we're making immediate dentures. So I am not the person who is the expert on this. You should really check out the works of, I cannot say his name, DeRosso, Lucio. I don't know how to say it. I need to get that right, but he is the expert. When I saw him present at the Digital Denture Symposium, the last event, the one thing that stood out in his suggestion for scanning that helped me was to keep in mind the distance that you're holding your scanner from the ridge. You think that you need to put the scanner right on top of the ridge, very close. And after that presentation, I experimented and I had a lot better success by pulling it away from the ridge and scanning a larger area. Another problem that I've noticed is that the AI scan feature is sometimes helpful and it's sometimes really not helpful. And when you're trying to capture borders, I tend to not use it. So I did want to share my video, but please don't make fun of me for how bad I am at scanning patients, because I'm not an expert at it. What I do is I have my assistant holding the cheek and I'm holding the tongue with the mirror. And when I get to the midline, we switch. So you saw me hand the mirror to her, and then we pick up. Now it's often that I get stuck, but one thing that helps me get unstuck is to trim the tissue like I just did. If there's too much tissue, we have found that by trimming it away, the scanner can help get you pick back up and move on to the other side of that ridge. So one person retracting with a mirror the tongue, and the other person holding the cheek and the lip. So not a great example, but those are the tips that I have found that help. And I am a believer in capturing the retromolar pad. So if I don't get the entire retromolar pad as well as the entire lingual, I call it a failure. So that sums up the 6 different situations, as well as all the different, tips and suggestions that I have. So I did want to just turn it back over to Carlo, and anyone else who has any questions for me, feel free.
Thank you very much, Valerie, for your clear presentation. I already have one question for you. Do you have any experience with other intraoral scanners?
Yes. So when I first started, experimenting with this years ago, I did a lot of my own research about comparing scans from my Trios, comparing it to different laboratory scanners, comparing the scans with scans from iTero, from OmniCam, all different ones. And I have found mixed results. So some scanners did not perform very well. Some scanners did really well and were very accurate. So, but one of the features that makes a big difference, in my opinion, is that, so for example, the iTero produced a very accurate scan. But the problem is that the iTero scanning head is huge, and it was more difficult to capture undercuts as well as deep and narrow ridges than with another scanner that has a smaller head. So the smaller size is helpful for this application. And so that's important. The other important feature is the depth of the scan. So from what I've heard, the Trios can scan something like 14 or 17 millimeters, depending on the setting, and being able to scan deeper makes a difference. So that was my experience. And I personally have used Trios for years, but my favorite is the Trios.
Okay, thank you. And then we have another question. I think this is more a question for Carlo. What is important for Excent to make a good design when using the reference denture technique?
Okay. Well, of course, a good impression, like Valerie already said, no? We need a good impression to start with. And for us, maybe I'm a little bit more tough than Valerie is. We really like open scans. So if you scan an existing denture, don't close the palatal side, because we have a lot of issues in the software then, and we have to go into different softwares like Mesh Mixer to open the scan up, and that makes it a little bit more inaccurate, and it costs us a lot of time to do that. So please, if you use the reference technique, don't close the palatal side of the scanned denture. That's maybe one of the most important things. Yeah.
Okay, thank you.
I have one more thing to add to that. After you've made your impression, you need to trim it, because leaving lots of impression material covering the teeth eliminates their usefulness for the technician.
Okay, thank you.
That's a good point.
And then the next question for Valerie. Can you make a bite scan only on one side?
No, I do not suggest that. You need to scan the bite on both sides and at least 4 teeth on both sides. So.
Okay. Just have to look in the chat. I think this is more a question for Carlo, maybe. What information do you need about changes of old dentures? Or maybe Valerie?
Yeah, I think Valerie already talked about it, but it's really important that we know what has to be different comparing to the old denture. And especially we see we get a lot of information that the dentist doesn't tell us how much the front teeth should be visible. So they say, well, you can leave the bite, but then we still don't know where the incisal edge has to be. So there are 2 important things. You have to tell us if we have to lower normally lower or keep the bite with the impression material. And we have to know how much the incisal edge should be visible with the impression material in the mouth. So these are 2 important things. Of course, the midline and the plane of occlusion is also important, but this is where we have to call the dentist up the most for asking them, do you also want us to lower the bite 2 millimeters, but how much teeth do you want to have visible? So that's important information for us. Yeah.
Okay.
I also see a very common error that the dentist will say that the patient wants these changes and will send pictures, but the pictures have the dentures with no impression material. And they say, okay, we want to have, more incisal edge, but what are we looking at? Because once you've added impression material, you are automatically going to increase the amount of display. And so if your goal is to truly copy the denture, you will have to ask for less incisal edge, remove the incisal edge up and back if you really want to copy how the denture was. Because once you've added the impression, there's more. So.
Okay.
Hi, Valerie. I'm Yuri from Preshape, and
Hi.
I have a small question for you. Did you already experience with the new scanning strategies that are available in the software?
No, they could not get them onto my trios. So
Okay.
I have not had a chance to try them yet, but I'm excited for that because it'll change a lot of the things that I'm able to do.
All right,
Okay.
nice.
Okay, thank you. Carlo, it's your turn.
Okay. So, yes, I want to talk a little bit of what kind of dentures we make on top of these beautiful trio scans. We use a carbon printer for printing these dentures. And we started doing some promotion just before Corona, but of course Corona slowed us down a little bit. So now we're starting to sell some more of these dentures than we did in the other period. But dentists really like them. So this is a really good product. We print them on the carbon printers. We've got 3 now. You can imagine you can print about, let's say, about 8 denture bases in 2 hours on these printers. So you can imagine that we don't fill them up with dentures yet, unfortunately. But we print a lot of models for our aligners, or a lot of accurate models for our implant cases and normal cases. So we use the carbon. That's actually our biggest advantage with these dentures. We had to wait until March last year to use the material in Europe. So Valerie was lucky, she could use it before, but we only could use it from March, and we could start testing them because it wasn't CE marked before. And we're the first lab in Europe that can use this material now. Yeah. So what are the benefits of the FlitZ Carbon denture compared to a conventional denture? Well, we see a better fit than a conventional denture because we've got very little shrinkage. So that gives you a little bit better fit. You don't have the porosities because it's very close. Normally when you pressure pack or you pour a denture, you always have micro porosities. And with this material, it's very dense when you print it. So one very big advantage, I think it's a strong material. It's stronger than conventional materials, and I think it's stronger than any printed material on the market, also the milled materials on the market at the moment. It's really a very strong denture. It's reproducible. A lot of old patients, they lose their denture or they get switched, or I don't know what happens with it, but we have to, it's easy to reproduce a denture using the digital technique. You could have a new denture in 4 or 5 days or something. Not a new, but the same denture that the patient had before. So that's also a nice thing. And of course, you can do it in less appointments if you want to, and digital techniques help you with this. So actually, we have 4 different kind of teeth on our carbon base, on our pink base. So we have the C1, the basic denture. This is a carbon base with printed composite teeth. Then we have the ML, the multi-layer, that has milled teeth from an Ivoclar disc. We also have teeth that come out of a card, like you see on the right side, the IPN and the Vigo. They are carded teeth. So you have a lot of different kind of teeth you can ask us for. I must be honest, we mainly sell the basic dentures with the printed teeth at the moment. That's the majority. So that's why I'll show you this before, the C1 basic denture. You can make an upper or lower or a full denture, an immediate denture, and we're working on the implant over denture, but we have to do some testing with that. But that's in the right picture, you see a denture straight from the printer actually after bonding. So it's not finished yet, but you can have also with this composite material, a monolithic composite material, you can have a really nice denture, especially in the mouth. It looks really nice. So yeah, don't be afraid of the monolithic materials, I would say. The disadvantage is we still have only 4 colors of this composite material: bleach, light, medium, and dark. But it's a very wear resistant material because it's a composite crown and bridge material actually. So it's CE approved, class 2A, so it can stay in the mouth, let's say, forever. So the big advantage in Holland is we have limited prices for our dentures, and all insurance companies in Holland, they pay for these basic dentures. So that's a good advantage too. I was talking about the multi-layer. So that's milled out of a block. You have it in 8 colors. A little bit more colors you have. It's a little bit more translucent, but you have to separate the teeth because they were milled and the small burrs cannot go in between the teeth. So you always have to do a little bit of manual finishing with the interdental parts of the teeth. So that's the multi-layer. That's the one we sell the second most. With the bonded teeth, you can only use it for an upper and lower together, and I don't know why, but we don't sell them so much. So it's mainly the other ones, and also the same with the Vita Vigo. It's not the product that we make a lot. So yeah. Well, Valerie talked a lot about scanning. We also have a nice scan brochure. I think Jean-François is going to show it later on. So you can do a carbon denture in 2 appointments or 3 or 4. But again, the most important for us is that you don't completely close the scan. Like you see here, please leave it open. See to it that all the borders are really nice, but leave it open. We already talked about this, the information the lab needs. So this is an example. You can use the points really nice to measure how much the bite is higher than without the impression material. So you please give us this information, how you want us to make it. So I used Valerie's information. I don't think Valerie's going to be able to read this, but I translated most of it in Dutch. So if you like this checklist, you can ask your Excent lab or ask Jean-François or me for this checkup list. So I've put all the points in there that Valerie talked about, and I think they're very good points. Also, I think you can use this also for your normal dentures, for your normal reference dentures. It's a very good thing to check and to use. You can, of course, make a try-in. What's nice about a try-in is the good fit. It fits really well. It fits like the real denture. You can check function. That's nice, of course. You can tell us if you want a different kind of shape or the shape is okay. You can check phonetics. I have to say, these dentures are a little bit bigger because they're not finished. So the real denture is going to be a little bit thinner than this one. So, but still, it's a very good thing to use for checking. And I think a stable try-in like this will help you to overcome making a third visit or something like that, to have a retry in. So stable try-in is a really important thing. You can even give it a patient that he can try it at home, but yeah, that shouldn't be your standard because that's extra important. But patients who cannot decide, you can even give them, let them try it at home. And of course, you can grind them and re-register them what you want. You can use them as an impression tray if the fit of the try-in isn't good. So that's you can use a try-in really, really well. This is what I wanted to tell you about. This is a quick overview. If you think your practice wants to know a little bit more, we can do a lunch and learn or an evening webinar, and I can tell you a little bit more about the different things we can do with digital dentures. So just call up me, mail Jeffrey, contact your Excent lab. And sorry, Jeffrey, I meant Jean-François. Sorry, Jean-François. And we can organize a lunch and learn in your practice. So I think we are. If there are any open questions, I don't know if there's something in the chat box.
No, No. Thank you very much, Carlo. Thank you very much, Dr. McMillan, for your presentation. Actually, we don't have more questions in the chat. If you have any question, do not hesitate to contact us. Ik zal anders nu even verder gaan in het Nederlands. Wij hebben ook nog enkele zaken dat we met jullie willen delen. Wij hebben vorige week ons werkproces intraorale scaninstructies uitgebracht. Voorlopig in een digitale variant. De geprinte versie komt er ook aan. Dus mochten jullie zo'n geprinte versie willen, stuur ons een bericht en dan sturen wij één op naar jullie praktijk. En daarin staan ook de instructies van het scannen en zo verder. En dan mag je naar de volgende slide gaan, Carlo. Nog ook even meegeven dat de promotie voor de Trios 3 Basic met 3 jaar gratis licentie verlengd is tot eind maart. Dus mensen die op dit moment, of tandarts die op dit moment nog niet geïnvesteerd hebben in een mondscanner, of misschien nood hebben aan een tweede mondscanner, we hebben nog een zeer leuke promotie voor jullie. En dan het laatste wat ik jullie nog wou meegeven, is dat wij op 17 februari een volgende webinar organiseren, maximaal digitaal met Excent tandtechniek, waarop de Trios mondscanner eigenlijk volledig wordt uitgelegd. Dus van A tot Z, wat dat allemaal mogelijk is, welke modellen er bestaan en wat al de mogelijkheden zijn die wij op dit moment aanbieden met Excent tandtechniek. Ik zou jullie van harte willen bedanken voor jullie deelname aan deze webinar. Hebben jullie nog vragen? Aarzel niet om ons te contacteren. Ik denk dat er op dit moment geen vragen meer binnenkomen. Kijk, voilà, dat zijn onze mailadressen, onze contactgegevens. Of contacteer jouw vestigingsmanager en die zullen jullie ook wel verder kunnen helpen. Dank jullie wel.